Do you want the presenter view? Do you have notes?
No, we'll just do this.
Yeah.
Pretty simple.
Cool. All right. So
Cool.
today is the 12th of May. We have Dr. Thomas Epperson, our
Hello,
PECU
everybody.
resident, with us. So give your undivided attention and see if I can hide this. There you go.
Okay, cool.
Showing up there. All right. Thank you. Go
Yeah,
ahead.
thank you. I'll try to maybe scoot over here a little so I don't block everyone's view.
Not this up higher.
It's okay. Okay. And if anyone has any questions during, please feel free to stop me. I'm happy to answer any questions. So we're going to talk about perioperative fluid management, which can be honestly pretty challenging. Let's see. There we go. So first, we'll just start with types of fluids. I think the most common thing we see here is LR. It's basically the most evidence-based fluid that shows benefit in initial fluid resuscitation in a surgical setting. We also do see a lot of normal saline, but that has been associated with hyperchloremic metabolic acidosis. Particularly, you'll see the chloride content's about 154, which is significantly higher than our normal serum chloride, which is normally in the 1-teens, 120s. It's also a little bit high on the sodium content, but generally in short amounts, liter and a half is okay. It's a good alternative to lactated ringers. Both LR and normal saline are isotonic, which means they're pretty similar in osmolarity to our plasma. We also have D5LR. That is a pretty common fluid in NPO patients that are maybe waiting for surgery on the floor, or in patients where actually have a little bit of PONV. We have used D5LR. There's a little bit of evidence that shows it might have some benefit in terms of nausea and vomiting. You can also do it in normal saline. And then we have other fluids like the 7.5% normal saline, also hypertonic saline. We don't generally see that here. You might see that in the neuro ICU in a patient with increased intracranial pressure, where they want to get the ICP down pretty quickly from just basically this hypertonic solution will draw fluid out of the tissues into the blood to kind of be excreted and decrease ICP. Then we have other things such as like the 5% plasma protein, which is essentially albumin. Albumin is kind of a controversial resuscitation fluid. You will see a lot of it used in the ICU. There isn't a ton of evidence for it in terms of like surgical resuscitation. There are certainly indications where maybe you've got like a spine case that's been going for a long time. They've been prone, they've gotten a lot of fluid, their eyes are a little swollen. You kind of want to avoid just more extravascular volume. You can use a more concentrated, such as an albumin, which will increase your plasma oncotic pressure, bring some fluid out of the tissues, and hopefully give you a bit more intravascular volume. Any questions about types of fluids? Cool. So reasons for fluid replacement, most commonly here, just patients are NPO, they're having surgery, they're going to lose fluid in the OR. So perioperative loss, we have NPO time, and especially as the day goes on, patients are NPO for a lot longer, and from personal experience, they tend to get a bit more hypotensive intra-op. These patients that have later surgeries, particularly the more older patients and frailer patients. So I know it's oftentimes, especially when we ask patients in the morning, you know, when's the last time you had food or drink? And they'll say, oh, I had that 7 o'clock last night, including other than a sip of water. Actually, we kind of recommend it. I don't think this gets told enough. Patients can drink clear liquids up until 2 hours of surgery. A lot of times they don't. They assume that, oh, we can't really take anything by mouth until 8 hours from surgery. So it's actually sometimes, which we don't really get to do this, but we tell patients, you drink water, drink water until 2 hours before you can do that. And that helps us out because patients that are hypovolemic, they don't do well with induction sometimes. We'll give them a bunch of vasodilators and their blood pressure will tank. And a lot of times that can be avoided just by appropriately hydrating prior to surgery. You also see patients that get bowel preps lose a ton of fluid. They're very hypovolemic when they get to pre-op. and even Pacu. Sometimes it's really hard to catch up on these patients that have had these bowel breaths. Decreased oral intake, whether that be patients that have head and neck tumors that prevent them from really taking anything by mouth, and or just, I don't know, really sick and don't have an appetite, don't have thirst. That can also cause hypovolemia. And then obviously trauma, blood loss, stuff like that. These patients are at high risk of perioperative volume loss. Then you have third space losses. Generally, that essentially means fluid is not in the plasma. It just third spaces into different compartments in the body. In minor surgery, we don't see a ton of it. We do see some, but not really clinically significant enough. But in major surgeries, big abdominal cases, stuff like that, you can see quite a bit of third spacing, and it's hard to measure because I don't know where it goes. It's not in the plasma, so that's where like physical exam and stuff like that play a big role. Then you have things like disease where people are vomiting, people have ileus, they can't really take anything by mouth. You've got septic patients who have a ton of capillary leakage, losing a lot of volume. And then I just put response to medicine. Like in the OR, we use a lot of medications that cause vasodilation. And it can actually be tricky because you get patients that are euvolemic and we use a bunch of vasodilators and we're like, why are they still hypotensive? And then give them a bunch of fluid and they're hypovolemic and fluid overloaded. So it can be a little complicated in terms of medication response or medications causing vasodilation. So the tricky part is assessment of volume status. You all are probably a lot better at it than I am. I think probably the most important thing is a history and physical. You know, what does the patient look like? Do they look dry? Do they look like chapped around the lips, poor cap refill? Do they have heart failure? Are they in active heart failure with like JVD? And do you hear an S3 on auscultation of the heart? Something that I had heard of but haven't really used that I actually, when I was reading, is super useful, is just a passive leg raise, which basically you just raise the patient's leg up and look at their blood pressure. It's essentially the same as like a 300 cc fluid bolus, which I didn't realize. And it's a good way to assess if they're going to be volume responsive. It's important to note that if it is pot and their blood pressure does go up when you raise their legs, that doesn't necessarily mean they're hypovolemic, but it does predict how they'll do when you give them some fluid. So if you run into hypotension and stuff like that, fluid, they're going to be responsive to it. We also do a lot of ultrasound from anesthesia. Basically, we'll just put a probe here and you can kind of visualize the IVC and have them take a deep breath. And sometimes they don't even need to take a deep breath to raise their intra-abdominal pressure to compress the IVC. You'll just look at it and it's just flat, which essentially means their volume down. And on echo, you'll see the ventricular walls of the LV just kind of like touching each other like this. That's also an indication that they're hypovolemic. Intra-op, this is when it gets tough because in a standard case where we don't have like an arterial line and stuff like that, basically we've got what we saw in pre-op. We've got how much volume we've given, how much volume they've lost. We have urine outputs sometimes if they have a Foley, which isn't the best predictor of volume status, but it is useful in combination with other clinical findings. They could be tachycardic and you give them like a 250 cc bolus to see if that helps. And a lot of times their heart rate will come down and they just need a little bit of volume. In bigger cases, we'll put in our arterial line, which is super helpful in terms of kind of assessing volume status because it gives us these systolic pressure variation and pulse pressure variation, which is essentially how your systolic pressure changes with the respiratory cycle. A systolic pressure variation greater than 10, which a number oftentimes will pop up on our screen, indicates that they're hypovolemic. But this is only useful in patients with an A line that are being mechanically ventilated. So when they get out here and they're not on the vent anymore, we don't have that reading. So this is only really useful intra-op. Sometimes you can just look at their pleth, their pulse oximetry kind of tracing, and you can see some variation in height with their respirations. It's kind of a quick and dirty way to, maybe they are hypovolemic and they do have some variation in their pleth. So a lot of tools. Basically what I'm getting at is you have a bunch of information that you kind of need to synthesize together to get a good picture of their volume status. And obviously, we give fluid in patients that likely need it from a hemodynamic standpoint. They've just had surgery, they've lost a lot of volume. And we always have to be conscious of, do they have CHF? Do they have CKD? Do they have things that would preclude a lot of volume? Okay. I'm going to come back to this slide because first I want to talk about kind of our strategies from an anesthesia standpoint of fluid administration in the OR. So in general, for any minor surgery, like a lap apnea or something like that, you can give a liter or two and most patients can be fine. But in major surgery, there are two different types of, I define major surgery as blood loss greater than 500. There are two strategies. You have the restrictive fluid therapy, which basically means all we do in the OR is replace what they lose. So we'll do like 1.5 to 1 crystalloid to blood loss. We'll replace urine output, and then we'll have about 3 cc's per kilo per hour of just kind of maintenance fluids for insensitive losses and stuff like that. That's restrictive fluid therapy. And so the reason I say there have been a lot of studies about being restrictive versus being more liberal in terms of how much fluid these patients get. And a lot of studies have shown that patients that have more of a restrictive fluid administered during the procedure actually tend to do a little bit better. It's a little subjective because all of the studies that I have listed here were in ASA 1 and 2 patients, so patients that didn't have heart disease, patients didn't have kidney disease, stuff like that. Some of them got bowel prep, some of them didn't. So there are a lot of like potential confounding factors. But they did find that, patients that got a little bit less fluid and just got what was replaced, what was lost in the OR, their bowel function returned quicker. They had less like edema post-operatively, fewer respiratory complications, and just about all patients except a handful didn't develop any like renal injury from fluid restriction. But this third study, the McKay et al. Actually used a restrictive and a more liberal strategy and didn't find any difference. So that's why it's an ambiguous thing, this fluid kind of balance in patients. It's tough. So we talked about the restrictive fluid therapy. Now this is more the other option for major surgery is goal-directed fluid therapy. And I'll start by saying that these patients, just about all of them, will have some type of invasive monitor that we can use to measure their fluid status, like an A-line. So first, we talk about kind of like fluid responsiveness. We've already talked about that. You can do a passive leg raise in the OR, you can do it pre-op, you can do it Pacu, it doesn't really matter. And then sometimes, depending on what monitor you have, you can measure stroke volume and see actually how they respond after a fluid challenge. For us, we just give them volume and see how that systolic pressure variation with the arterial line changes. So essentially with goal-directed fluid therapy, we want to calculate, and it's very hard to do, but just calculate their volume deficit. I should say more estimate their volume deficit. We want to keep them euvolemic. So for major surgery, we replace all of their losses just like we do in the restrictive manner. But we also keep them on, we want to keep them a little bit positive from where they were pre-op, about 1 to 2 liters. And we basically use the systolic pressure variation from the arterial waveform to guide how much fluid we're giving. If it's less than 10, that generally means they're in a good place. But if it's greater than 10, then we know that they probably need some fluid. So we just follow that for the entire case to try and keep them euvolemic. So this is just kind of a graph that I thought was a little useful. So at the bottom on the x-axis is patient risk from low to high, and on the y-axis is just surgical risk. So if you have a patient that is not very high risk and having a pretty minor surgery, you're not going to do goal-directed therapy. You're going to give them a liter or 2, liter and a half, and that'll be that. But in patients that are higher risk and have higher risk surgeries, that goal-directed therapy kind of comes into play. And in the top right corner, you'll see that, already considering SICU admission in a high-risk patient getting a high-risk surgery with a lot of blood loss anticipated. So complications of fluid administration, which I'm sure you all are aware of, patients that get too much fluid, you get a lot of tissue edema. Wound healing is worse and it gets complicated, and then they get wound infections. Their bowels take a while to return to function because they're edematous. If they have heart problems, they can get pulmonary edema and they can get, need diuresis and CPAP and stuff like that. And then you just get they get swollen and then they have trouble getting out of bed, and it can just cause a lot of problems. And then hypovolemia also, you're not going to have as much preload. Your cardiac output's not going to be that great. And then your tissue perfusion is going to be worse. Your wounds aren't going to heal. You can get, kidney injury, multi-organ failure, depending on the extent of how hypovolemic you are. So that's why it's so important to be euvolemic. And again, it's really hard to achieve. So it's a fine line that we try our best to follow, but it's where kind of assessing patients and using the data that you have to assess their fluid status is really important. So choosing the right fluid, most of the time, just crystalloid, isotonic crystalloid, like lactated ringers is what we use in the perioperative setting. We talked about the normal saline. We don't give a ton of it, but it's fine for a liter or so. Then we talked about colloids like albumin and how they haven't really been shown to be significantly beneficial, but sometimes, you'll get like patients with liver disease who have a bunch of ascites in their belly, who have a low albumin to begin with. Albumin's a lot of times beneficial for these patients, or like burn patients who already have a ton of third spacing from capillary leakage. And albumin will help, hopefully, keep most of the volume we give them inside of their blood vessels and their plasma, as opposed to just continuing to leak out. So albumin might be useful in that scenario. It's just kind of it's a clinical decision to give albumin. Sometimes we'll give albumin 1-to-1 with blood loss until their hemoglobin reaches the point where we want to transfuse them. This is just kind of a little diagram that I thought was pretty good. So it talks about in the pre-op kind of period, encourage them to drink fluids, not milk or food, but just clear fluids. It'll help us in the OR, and it'll help when they're done with surgery to keep their blood pressure up. And then we talked about intra-op. You've got your goal-directed therapy if it's a big surgery, or the fluid restrictive, depending on which one you choose. And just want to keep them a little positive to kind of avoid hypovolemia in these patients. And then a post-operative period, we want to get them up, we want to get them moving, we want to get their IV out and have them drinking as quickly as we can. That's safely for the patient. And that's really it. What questions can I answer?
I have one on the passive blood rate.
Yeah.
I was just reading about this myself, and they kept saying to get a positive, but they gave me no parameters as what a positive is. Did you find that?
Generally about 10 to 15% increase in their like systolic blood pressure.
Gotcha, because I was like, why could I have a 1?
Yeah.
Got it. That's
Other
I was going
questions?
to ask you. Oh, stroke volume.
Yeah.
So I was reading about that too and measuring that. I mean,
That's tough.
yeah, because
Yeah.
so you have to have the way I would do it was a swan or a T.
Exactly, or like an esophageal Doppler, which we don't routinely use in the OR
that's
here.
what I was.
And that's why like our choice for, the goal-directed therapy monitoring is a line.
Gotcha.
But then that gets tricky when they come out of the OR and they're not being mechanically ventilated. So then we can't get the like systolic pressure variation values. So at that point, we're like, well, here's where they were in the OR. So I think they're euvolemic. It hasn't changed since we've extubated them. Or we can be like, our SPV was pretty high throughout the whole case. They're probably going to be a little volume down. So I think it's more of our job to say, here's where we were intra-op. This is kind of our starting point in terms of their volume status.
Yeah, it is tricky. You're right.
Yeah.
You don't want that fine line.
It's tricky.
And then you get those folks, and of course we get them here, the ASA 3s and 4s with their heart failure and renal failure. Yeah. And you talked about albumin, so this has nothing to do with this talk, but we just had a case of Jehovah's Witness. A lot of Jehovah's will not accept albumin. So another little kink in the, how do we resuscitate you?
Yeah.
So something to think about.
Yeah.
You came to the ER too, we would always, we'd hang normal saline, like the bolus patients. And then when I came here, it was like LR. And,
Well, yeah.
I appreciate
Yeah.
like the rationale that you gave, like
Yeah.
the whole,
Mhm.
that just makes more sense why we use
Yeah.
LR here, whereas with ER, you have that.
Well, and I'm old enough in the ER, we'd give them 5-6 liters before somebody asked how much fluid have they got, right? And then you're in deep trouble because now up in the ICU, they're fighting that they're fluid overloaded. They're going to put them on, dialysis or CVVH and walking that line. But
Absolutely.
That was good.
Yeah,
Thank
that's
you.
very
Thanks. Hopefully it was helpful.
simple topic, but still important for us.
Yeah.
Because of,
Do you find, so this is another trick of the trade that us PACU nurses kind of keep in our back pocket. we do it for our like post-op Mountie hanging a little D5 LR. In caution with like overload or anything like that. But I don't know if there's any true research about it.
There are a few small studies that show it might have some benefit. No like big studies, but honestly, I feel like if it works, it works. I mean, I'm sure you all know, like you've probably seen if it works. I haven't, but I've heard that it has been beneficial in a lot of patients. So
lots of times these patients are super dry. You said you assess them like, do they look dry? They don't have any veins. They are super good about having surgery and they weren't doing anything the night before or nothing because they want to be a little bit extra, So they come in here, they have no veins. They are super dry. We don't give them fluids in pre-op. They go have surgery and they come out and sometimes I hear they only have 400 of fluid, 500, 400. And they haven't been drinking for hours and hours. And then, of course, they are nauseous. They are vomiting. We give them a liter of fluid and we'll see how they get better. So how about asking us how they do with fluid?
absolutely.
Like you give, it's no wrong to give them a 500 or a liter of extra fluid and you'll see how they just get better and go home.
Perk up.
Right.
Yeah. Especially those little old ladies, because they'll say, oh, I drink all day. Well, my little old lady, Mom, how much are you drinking, Mom? Oh, that glass of water is sits there all day. Oh, dear God. So, yeah, that's, because they don't want to go to the bathroom.
Yeah.
Like, we don't.
But just thinking about hours and hours of not having any fluids, going in the OR, having a procedure with 400 cc's of fluid is like ridiculous. And I'm like, what's the rationale?
I think honestly, it's probably the fact that we're so used to just asking, oh, when's the last time you had something to eat or drink? And I'm like, oh, 8 p.m. I'm like, oh, that's good. And we don't even think, oh, well, they haven't had water in hours. So that's something
They
that,
don't have any veins because they
Yeah.
well, I didn't drink anything. I shouldn't. And they are really, really,
Yeah.
preparing themselves for something we haven't fluids.
yeah, that we need to do a better job on
And then,
anesthesia
of course,
standpoint.
they're really difficult to recover because they didn't have anything, right?
Yeah.
I open up the fluids, I let that bag of fluid run, and then they are just fine. They can go home.
Yeah.
Okay. Because they didn't have anything, and they're not ready to have water,
Right.
anything in recovery right away.
Yeah, absolutely.
I think we are super strict in the OR about fluids, and it's
Yeah,
not the best recovery for this patient.
agreed. I agree.
Let's see if anybody on the Zoom have questions. If not, I don't think so. All right, cool. Thank you, guys. Thank you.
Cool, thank you all.
Thank you.
Appreciate it.
Anyone else join, or is that all of them?
I think we had everybody. Jess, Jamie, Mike, Christy, Aaron, Kathy. Does it?
We got it.